by Grace and Katerina, respectively, are representing UCL, Birmingham, and Imperial Pediatric Society. So to give you some background, traditionally our university separately organize annual in-person conferences. However, during the lockdown in 2020, when in-person activities were cancelled, we decided to combine our efforts and organize the first ever national pediatric fully virtual conference. And so naturally we're faced with the immense challenge of translating the high levels of engagement we previously enjoyed during face-to-face conferences onto an online platform. And so our solution was to test the following theory. By varying both the modality of the classical lecture approach as well as the degree of interactivity between sessions, could we replicate the high levels of engagement? And so we assessed the success of our multimodal approach by surveying 82 attendees of our two-day conference. And we specifically gauged using numerical and qualitative methods, which modalities were more successful in promoting engagement, and indeed whether the variation within our multimodal approach encouraged sustained participation throughout the two-day conference.
We specifically asked attendees for unstructured feedback so we could try and get a real insight into their views and opinions on the different modalities that we used, rather than just generating a sort of engagement score. The standout positive feedback that we received was about the quality of the speakers and the variety of the types of talks. There was no specific and significant positive feedback about small group sessions, which we had hypothesized would be quite high scoring, especially as one of the workshops we ran had a 3-to-1 attendee to speaker ratio. However, actually, in fact, when we analyzed the data, we found that the small group sessions were rated the least engaging at a statistically significant level.
So these lower scores in small group sessions have actually been observed in literature. And one of the proposed reasons here is that there is less structure and maybe less perceived importance. Now, we really observed a high level of engagement, as you can see here, across our 3 main talks. And there was no statistically significant difference between these 3. And using the unstructured feedback we got, we really managed to link that back to the format, the variety, this idea that if you have main lecturers who are very varied in their lecture approaches, you can keep very high engagement. So we recommend not only sticking with main lecturers rather than small sessions, but we'd also like to offer this idea that varying lecture approaches plays a very important role in engagement. Thank you very much.
Thank you very much. You must have that train to catch because you got 10 seconds left. Go, go, go. Get your train. Thank you, guys. Right, can we have number 1, please, who is you? I'll put my, so that means 2 minutes, and that means 1 minute.
Sure.
And then this is the ultimate death nail. Go.
Hi. Oh, hi, my name is Ramit. I was involved in a project that looked at whether a technological tool can help to improve clinical decision making. The tool is called DemDX, and what it does is guides clinicians through initial presentation, looking at how to diagnose a patient, then looking at how we're going to investigate and treat the patient. It's used as an educational tool, but also it's now being rolled out in clinical practice to determine whether it can have real life value. So what we did was we looked at the clinical referrals in a team in Rochdale. They're called the Urgent Community Care Team, and they work in the community where they triage, they manage patients in the community to prevent referrals into secondary care. What we did was we took 192 anonymized cases and reviewed them. We put them through the DemDX tool, and we looked at the quality of the clinical referrals themselves. What we found was when we were looking at the actual team's referrals against the local and national guidelines, 47% were appropriate. This is not to say that the rest of them were inappropriate referrals. This is just saying that we could improve the rest of the referrals. When it was but comparing the actual actions that were done by the team and comparing to DemDX, which is the platform, we found there was 85% appropriate referrals and only a 15% in where they could be improved. And as the platform updates its guidelines, this can improve and help guide clinicians in the management of patients. When we talk about improvable referrals, this could be simply sending a patient rather from one hospital, which only has an ophthalmology unit, sending them to a different hospital, which may deal with heart problems instead. So what we're trying to do now is use DemDX and use real-life clinical cases to make sure whether what we found actually can be applied in clinical practice and provide health support for allied healthcare professionals. We'll update you with further results in the future. Thank you.
You guys are really good at timekeeping. Right. On to number 3, who is, yeah, go for it. Let's. Okay.
Good afternoon. My name is Armin Sen. This is my co-author, Alex. We're both medical students at Barts in London, but we do a bit of machine learning research in our spare time. Together, we sought to investigate the use of consultant-led virtual review as a means of offering 7-day services in the UK. 7-day services were sort of first proposed by the government in 2013 after they realized that there were disparities between weekday and weekend care, noted as the weekend effect.
So this effect is partly due to less staffing on weekends, and in particular, less senior clinicians available during the weekend. As a result, there's a big push now to kind of improve access over the weekend to senior consultants. And we sought to use telehealth as our means of improving this access. We sought to do this to kind of work out whether a virtual review process would offer equivalent benefit to an in-person consultant over the weekend.
In order to do this, patients admitted were allocated to 2 different groups, the control group and the virtual group. Those in the control group were reviewed conventionally by an in-person medical team and an in-person consultant, and those in the virtual arm were reviewed by an in-person medical team and a virtual consultant who accessed the patient records remotely. Measured outcomes at 4 weeks were things like length of stay, mortality, duration of ward rounds, sort of as a reflection of clinical workload. Patients were also surveyed on their attitudes towards virtual review.
So in total, over the 4 weeks, we recruited 32 in our virtual arm, 21 in our control arm. We found no difference in terms of demographics, so no difference in age, sex, ethnicity, or reason for admission. We did find no difference as well in length of stay and mortality rates, which we thought would reflect kind of an equivalent care in our virtual and our control arms. We also found a decreased time taken to review each patient virtually, which represents kind of a streamlined approach in which the consultant can review notes in between bays. And finally, we found positive attitudes towards virtual review from the patients.
The majority of patients actually reported that there was clear communication, appropriate levels of privacy, and sort of high levels of both trust and satisfaction. These results, alongside a significantly reduced time taken to complete virtual review, highlight the importance and the potential of virtual programs as a sort of cost-effective substitute for conventional review.
So going on from here, we want to try and work out whether a virtual process is a significantly improved standard of care compared to conventional weekend review, which often doesn't have a consultant available. Thank you.
Thank you very much. This is like a military operation, this. Honestly, in my day, never stick to time like this. How interesting. So they're saying consultants don't need to get out of bed. That's right, isn't it? That will probably get quite a lot of marks from the panel. Daniela.
Does this work?
It should just, yeah, the mic works. Have you got a presentation? Or? Yeah. Okay. So we'll start the timer, but you can introduce yourself whilst they. All right, it's up.
This is not my poster.
Which
This is the.
this is not our poster. This is not Daniela's poster. I mean, is it better than the one that you've got? Because you could run with it if you want. No. Does that look familiar?
Yes.
Let's stop there.
Great. So good afternoon. My name is Daniela and I'm a fifth year medical student at Imperial. And today I'm going to be presenting my intercalated BSc project. Anterior approach total hip arthroplasty is a muscle sparing operation that may have some advantages in the short term over other approaches, with the potential of day case arthroplasty in the future, which could represent a substantial cost saving benefit of around 30% per patient. However, the operation is difficult with a strenuous learning curve. Better teamwork in surgery has been correlated with improved staff confidence, reduced errors, and improved patient outcomes. Immersive virtual reality has been shown to be an effective method of training. However, it is yet to be tested in the team setting. Therefore, we wanted to see if virtual reality team training is better than solo training for the acquisition of both technical and non-technical skills in this surgery. 10 surgeons and 10 scrub nurses were randomized to either solo or team IVR training, shown in Figure 1A. They underwent 5 sessions spaced 2 to 14 days apart. Then they underwent a real-life assessment shown in Figure 1B, where they performed the surgery on a high-fidelity model in a simulated operating theater. Video footage was assessed for technical outcomes such as procedural errors, time, and acetabular component orientation, while non-technical skills were assessed using the validated NOTEX and NOT scores. As shown in figures 2A to 2D, teams were approximately 28% faster than solos, with 35% less errors and superior communication skills scores. Our findings are in line with the existing evidence base, showing that 1, IVR is an effective method of training, and 2, that team training is superior to solo training. Study strengths include the fact that this is a prospective randomized trial demonstrating real-life transfer skills from IVR to the simulated operating theater. To improve, some limitations include the fact that there was a multifarious scrub nurse population, lack of participant blinding, and the fact that this occurred in a simulated and not actual operating theater. To improve, structured non-technical skills training could be implemented, as well as expert benchmarking by stratifying surgeons according to their experience. To conclude, multiplayer virtual reality training appears to be an effective medium for training surgical teams with faster, more accurate surgery with development of superior communication skills. However, more data is required to assess whether this translates into superior patient outcomes. Finally, this could act as the foundation for the implementation of multidisciplinary learning within medical and nursing school curricula. Thank you very much for listening.
Amazing. Thank you very much. And straight on to Katharina, Grace, and Simon. Oh, they've got them who are halfway to Cambridge. Yeah. Maria. Maria? No, Maria's okay. Is Maria a video? Can we get them virtually?
Okay. Okay, now that everybody's here, the business producer of the stage is going to count down. Everybody knows what is the order of their presentation.
Maria, you are the first presenter. Could you please present your work?
Yeah, hi there. Good afternoon from Munich. Can everyone hear me? Can you hear me all right?
Yeah.
Yeah? Okay, so yeah, greetings from Munich. We had a snowstorm here today. It's really cold, and I'd love to be with you in London at the Giant Health Event 2021. So my name is Maria. I'm a medical doctor, and I'm part of the research group for neuropathology here at Technical University in Munich in Germany. And I'm really happy to take part in this innovative medical research program at Giant to present to you an upcoming technology. It's called confocal laser endomicroscopy, and we were working with a microscope called Convivo by the company Zeiss. I'd love to share my screen with you guys. I hope this works. Yeah, so here you actually see this microscope. And with this microscope, a neurosurgeon can detect remaining brain tumor cells in vivo in theater after IV administration of a fluorescent drug, which is visible intravascularly, for example, here, as you see. And during brain tumor surgery, it's not always easy for a surgeon to decide whether all the tumor is already removed, like in this slide, or whether there's still some remaining tissue, like in this glioblastoma here, for example. And yeah, so a tumor surgeon also has to be aware of the risk that removing too much of the brain tissue increases the risk of neurological difficulties postoperatively. But beside the tumor resection control, the other great benefit for patients is that this technology provides real-time histology at the operating table. So our current worldwide gold standard is depicted here. So the surgeon would send intraoperatively a little probe from theater to pathology. They would make a fast frozen section, which could look, for example, like this, glioblastoma multiforme, or similar to this, brain metastasis of a squamous cell carcinoma. And then they would decide whether resection needs to be extended or not. So with this technology, the step of a fast frozen section could actually be skipped, thus reducing the length of an operation. Now, whether this microscope will actually replace the need of a classical pathologist will be examined in further studies in the future. So, that still remains to be examined. Yes, before implementing this microscope into surgery, a lot of preliminary work was necessary in the laboratory where I examined 73 tumors, just trying to find out what normal tumor looks like or what the infiltration zone looks like, as I showed you before. So concluding, my results are quite promising. I'm looking forward to working more with this microscope, and yeah, it still needs to be seen what other advantages this microscope will have in the future. So yeah, thank you very much for your attention. And if anyone has questions, I'm more than happy to try and answer.
The next speaker will be Dr. Sander Bekasi.
Yes, I'm here.
Dr. Sander Bekasi, could you please present your work?
Yes, please. Good afternoon. My name is Sandor, and I'm from the Health Center of a Hungarian NGO providing primary care to people experiencing homelessness. I'm just trying to share my screen. I hope you are seeing it. So, as you might expect, it was not an easy task before the COVID-19 pandemic to provide healthcare to homeless persons, and it just got even harder. As a regular in-person health services became risky, we had to decide how to continue care. In order to ensure the continuous treatment of chronic conditions, we moved into the direction of digital health. As a first step, we did an attitude survey among homeless persons and got surprising results. Their openness towards online medical consultations appeared to be the same as our national reference population. This served as a wake-up call, and we started to set up a pilot in 4 homeless shelters providing long-term accommodation. We have recruited 75 participants, and we offered them a 6-course telehealth service focusing exclusively on chronic diseases. On the originating side, in the shelters, the patients were supported by an on-site telecare assistant, and they were able to talk to a physician, either a GP or an internal medicine specialist, via a live online video call. These online visits were scheduled every 2 weeks. The results speak for themselves. 55 out of 75 participants completed the full 6-course telecare program, and the total number of 415 online sessions was delivered. In 98 cases, the physician initiated the therapy modification of chronic disease medication, and that supports the medical relevance of this pilot. The average client satisfaction was above 4.5 on a 5-grade Likert scale, and the overall rating of physicians showed an average of almost 4.8. Our conclusion is that this was a highly successful pilot and a strong validation that medical care of chronic conditions via online video consultations might serve as a powerful tool to enhance the care continuity among homeless persons. In shelters where on-site assistance and technical infrastructure are already available, such programs can be established relatively easily. So telecare programs might reduce the digital exclusion of underserved populations, such as homeless persons, and to lead better health equity. Up to our knowledge, this pilot targeting specifically homeless shelters, and so homeless shelter residents, is unique throughout Europe. So thank you very much for your attention.
Yeah, the next speaker will be Partha Namdari. Could you please present your work?
Yes. Okay. Good evening, ladies and gentlemen. My name is Partha Namdari. I'm a 6th-year medical student from the University of Debrecen in Hungary. And today I would like to present you a topic about, I will just share my screen right now. Today I will present you a topic about the hemodynamic effects of the positive ionotropic agents, which is really common use. We really commonly use it in the episodes of acute heart failure. Basically, we know that, of course, the positive ionotropic agents are really good when we want to acutely manage an acute heart failure. But as we know, again, there are many other side effects that come with it in the near future for the patients. And basically, for this presentation, I would like to focus on this table, which I have prepared on myself. And basically, I've concluded some important and the most commonly used positive ionotropic agents in this table, and we will go through the hemodynamic effects that they will have on our body. In the first stop, we have the dopamine. Of course, we can see increased heart rate, increased cardiac output. We have vasodilation as long as we have the low doses, but it can cause vasoconstriction in the high doses. Well, this will lead to increased mean arterial pressure, and we know that they are super arrhythmogenic, and they interestingly shows an increase on effect on mortality. So even though we really like it in acute heart failure, it's basically not really useful for the patients. And on the second stop, we have the dopamine. Again, increased heart rate, increased cardiac output. This one does cause vasodilation, but in the increased doses, it can cause vasoconstriction. Again, increased mean arterial pressure, arrhythmogenicity, and increased effect on mortality. We have the epinephrine, same results. We have the norepinephrine, same results almost, except for vasodilation. But the interesting fact from my research comes from these 3 drugs which I'm mentioning right now: the Phosphodiesters inhibitors, the omecamtiv mecarbil, and the levosimendan. Well, the Phosphodiesters inhibitors Interestingly, they decrease the heart rate, increase the cardiac output. They can cause vasodilation, no effect on so basically no vasoconstriction, increase in mere arterial pressure, positive arrhythmogenicity, and increase in mortality. So even though that we were really relying on these drugs to open a new path in the cardiology, they are basically not really useful and they are not really promising. Omecamtiv mecarbil, which is a really hot topic because there was a galactic heart failure study which was conducted in 2021. I mean, the results were conducted in 2021, and again, it was disappointing. It didn't show an increased a significance increase. Yeah, of course, it can cause decreased effect on mortality, but that's only a preclinical data. Levosimendan, which is a relatively new drug, and it's only been used for 20 years. Again, this has been the ideal drug, sort of, but again, the
Hi, Parsa.
significance of mortality.
Your time has finished.
Oh, okay then. Thank you very much for your attention.
The next speaker will be Viraj, Alina, and Karanjot. Viraj, Alina, and Karanjot, please present your work. Viraj, Alina, and Karanjot, could you please present your work?
Yeah, Viraj, can you share screen?
Yep, are you able to see that?
Yep. Love it. Good evening. I'm Karanjot, and we are 3 medical students from Imperial College London. And thank you for the presentation about evaluating digitized neurofeedback and its potential to become the future of personalized mental health care.
So the obvious question might be, what is neurofeedback? Neurofeedback is a form of biofeedback, enabling them to respond, self-regulate, and alter these activities. Since 1992, uncovered the therapeutic potential for neurofeedback in the treatment of eating disorders, impairment, and ADHD. However, neurofeedback has not been adopted worldwide, as current forms of it require the use of EEG or functional MRI, both of which are costly equipment and have limited availability. Stress Point Health application Sphere aims to provide one of the first forms of feedback directly to the Sphere uses auditory with the aim to find out frequency that a user associates with a specific stressful trigger. The aim of this study was to establish whether Sphere was more effective in improving the symptoms of stress and anxiety compared to the marketplace leading digital tool.
Between May to June 2021, we recruited 39 participants opportunistically via social media. Participants were randomly assigned to one of the 3 cohorts, so either the Sphere, leading application, or leading application with artificial stressor cohorts, as seen by the figure 1, which is the flowchart. Each participant completed questionnaires pre and post completion of a 20-minute session about the relevant apps. We assessed change in heart rate, respiratory rate, and cognition pre and post session. And in addition to this, we asked participants about their perception of their own stress state. One-tailed Mann-Whitney U-tests or Welts tests were used to assess significance between cohorts, with p less than 0.05 denoting significance throughout.
Figure 2 demonstrates our major outcomes. We found that there was a statistical significant 11.6% decrease in heart rate from pre to post session in a sphere cohort, the yellow bar in figure 3, compared to the leading meditation cohort, the pink bar, where we actually saw a 3.02% increase in heart rate pre to post session. And when compared to the leading application with an artificial stressor cohort, the green bar in figure 2, where we found there was actually a 1.72% decrease pre to post session in heart rate. Our investigation stands out as a pilot study. Taking that into account, we had some limitations, such as a lower sample size of 39 participants, limited age range, and diversity of mental health characteristics. However, in the future, we believe that certain steps can be taken to take our research further. Analysis of brain frequencies pre to post session could be taken. What could be further done is by comparing the effectiveness of Sphere to traditional pharmaceutical methods to treat stress, anxiety, and even PTSD. Thank you for listening to our presentation.
Claire is in. Claire's in.
Dr. Miss Claire Fine, could you please present next?
Okay, hello everyone, and thanks for coming. My name is Claire Fine, and I'll be speaking about the Virtual Healthcare Hackathon as a cost-efficient way to promote innovation and multidisciplinary collaboration in medical education. So our goals with hosting a hackathon was to provide medical trainees with exposure to multidisciplinary teamwork and core concepts of medical innovation. There right now are very few opportunities for medical students to get involved in innovation, and the opportunities that do exist rarely include collaboration with other disciplines. And we know that multidisciplinary collaboration is crucial to effectively address complex healthcare challenges. And our second goal was to actually support students in building real solutions to pressing medical challenges. So what is a hackathon? Well, it's essentially a design marathon where students from all backgrounds, from all over the world, come together virtually and spend that weekend building prototypes to unmet clinical needs. So this could be any clinical problem. And then we also had some specific challenges, such as the best COVID-19 hack. And throughout the weekend, there were workshops and mentors to help the participants. In terms of meeting our goal, you can see our results that we had 33 countries participate, with the most participation from Canada, United Kingdom, and United States. And there were 30 disciplines that participated. So medicine, biomedical engineering, computer science, we had pharmacy, nursing, economics, and each team had at least one discipline. So it really was a multidisciplinary, global, collaborative event. Our second goal was to see if students could create some real solutions that create medical innovation. And I wanted to highlight one solution, which was the best COVID solution. And it is a machine learning algorithm that improves ICU bed allocation with the aim of reducing surgical shutdown. It takes in COVID case data, elective surgery demand, and urgency parameters depending on the type of surgery, and creates an ICU bed schedule. And this was created at our hackathon, and it's 97% accurate for actual cases. So in conclusion, hosting a healthcare hackathon, it's resource saving, it's quite cost efficient being virtual, and it's a way to encourage medical trainees to think creatively and embrace innovation. It also creates prototypes and quality solution in just a few days. So an emergency department, for example, that needs some prototypes, has an idea, has a challenge that needs solving, could use a hackathon. And our next steps is looking into how do we take these solutions that are created at our hackathons and keep them going, keep developing them. Because there are so many great ideas that come out of a hackathon, but getting them to a next step, to a company or to getting into a startup after the hackathon instead of just a solution. Thanks so much.
Okay, the next speaker will be Abdul Hamid. Could you please present your work? Yeah, he's joined right now. Abdul Hamid, could you please present your work? Abdul Hamid, please unmute your mic and your video, please. Abdul Hamid, could you please present your work? Yeah. 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 Could all speak?
Oh, Professor Shafi is here. Dum dum dum. We're just about to present. One of the prizes is to have dinner with this man here. So, I mean, look, having dinner with the mighty Professor Shafi Ahmed is fine, but the question is, where do you have it? And you have it at the Ivy. So, whoever wins, eat well and eat hard. Not any old Ivy, the club, the upstairs bit where students aren't allowed. so, don't tell them you're a student and hide your NUS cards. Right. First place is not in this room, sadly. Oh. It is Dr. Sandor Bekasi. I'm not sure if he can hear us or not. Dr. Bekasi, can you?
Yes, I can hear you. Thank
Oh,
you very
excellent.
much.
Are you crying?
Almost.
Tell us how you're feeling at the moment. How emotional is it? I'll give you the mic.
Now I can hear you.
You need a speech. Otherwise, we'll withdraw the first prize.
Thank you very much. I think, yeah, my colleagues did a great job with this pilot, and I think it's a novel tool for people who are experiencing homelessness and really in need. So thank you very much.
Thank you. So, do you want to thank me for being an important part of your life or anything?
Of course.
Yes. Remote consultations for the homeless. Right. We're going to do second. This is. I know we should have done it the other way around, but there's a reason for this madness. This is as crazy as it gets at Giant. Because there is a special surprise for you with Shafi One Night. Number 2 is Dum Dum Dum, Alex and Armita.
Thank you very much. I'd like to thank my mother. Is that what you want? I'd like to thank the virus. Not many people would thank the virus, but I think that the virus deserves a mention because without it, we wouldn't have this boost in digital health and virtual review. Thank you, coronavirus. Thank you to the Omicron variant too, prolonging the process.
There are always, you never quite know what to do when you're sharing. Give that microphone away. This mic is not leaving my hand. You get 50. You get £50 cash. Now the reason normally we do it in reverse. The reason we've done. I don't know the difference between stop and repeat. I'm going to go on a course. The reason we've done this is because we've got a special surprise for you guys. Because we have searched hard in our pockets, haven't we? And we have found the money without asking you, Shafi, but I'll pay for this. We decided to give 2 third prizes, not 1, but 2. And they are 2. That person is not in this room either. Over to you guys. The suspense is just palpable. Claire, are you there? Can you hear us? These poor people here. Claire, do you want to say a few words? Virtual Healthcare Hackathon.
Thank you so much. Thank you so much. It's such an honor. All the presentations today were amazing. I learned so much, and it was such an honor just to present in front of everyone who's so renowned. And thank you so much for this opportunity.
Claire, you did really well. The hackathon for medical students would have been even better if you'd got some results in there. So there's a bit of feedback for you. And you'd ran to time as well. So £25 coming out of my children's hard-earned, out of my pocket. Or I'll ask Barry. And the last person is sadly Viraj, Elena, and Karen Joel. Are you? Hey? Because sadly for this lot, look at them. They come here, make an effort, risk the tube. Do you want to unmute yourself?
Hi, thank you so much.
That'll do, I think. Short but sweet. All right, I'm really sorry for the people who are here. What have you learned? Do it remotely. You're more likely to get prizes. Thank you so much, guys. And remember, it's not the winning. It's not having meals with celebrities in fancy restaurant. It's not about earning cash on Cyber Monday. It's about being part of that journey. Yay! We're done.